Thanks for joining us on the Virtual Global Spine today. Sorry about the lack of organization a little bit. We've had a late withdrawal, but I'm delighted to say that instead of just listening to me going through cases again, I've roped in John Kimball to join me to discuss a case today. Probably be a little shorter than usual in the session time, but that's fine. As you know, this is like a rounds and we just go through cases. Good to see a bunch of people joining online. Please put any text messages you've got in the chat box for us, and either John or I will try to get to them. Ali Baj is here as well in the background, and Amna, as always, is providing her wonderful tech support for us. So yeah, good evening to those in the US and South America, and late good evening to those in Europe. Good morning to those in Asia and Australia. And I'll get going on a case of mine in a moment. I did want to introduce John, who's kindly agreed to join and criticize my case today while we discuss a few things. He is an orthopedic spine surgeon. He works in private practice in Utah in the Salt Lake City area, and he's got a big and diverse practice. And I think a lot of us have seen his work on LinkedIn. He is an outstanding surgeon, obviously very technically gifted, and also seems to make the right decisions a lot of the time. So I think it's great to have his input, and we might have to rope him in to a few more of these sessions in the long term.
I like hearing you say a lot of the time. I like that. I can't wait to hear what that means.
Well, I think I mean, none of us get this right all the time. And I think if the day we give up learning from our mistakes is the day we should probably retire.
Totally agreed.
For this game. So yeah, we're excited that you're on here to have a chat about the case. And I think this will just lead to a range of discussions, and some of it's going to be sort of philosophical, and some of it's going to be practical advice. So I'm just going to load into my case. If you give me one moment. Sorry. Seems to work now.
Yes,
did it just move slide? Excellent.
There we go.
Yeah, apologies, technical difficulties. Good spine surgeons aren't always good with computers, except maybe Mike Kelly. I don't know if you've seen Mike talk, but he's an amazing IT person. So yeah, we got the screen sharing working now. Okay, so we're going to discuss a case in some depth, and I'm going to talk you through this one. I put a little teaser of this up on LinkedIn earlier, but this is a patient of mine who is a 63-year-old female at presentation, and she had in 1978 a posterior spinal fusion through the revolutionary Harrington rods. And I think a lot of us have seen these cases in long-term follow-up, and it was obviously revolutionary at the time, but there's a set of problems that go with Harrington rods. 1978 was a big year for me. It was the year I was born. So this instrumentation is as old as me. She was fused from T5 to L2 then, spent time in a full body cast afterwards, did not go back for exploration. So a lot of these patients had initial Harrington rods and extensive iliac crest bone grafting, and then they would go back and re-explore the fusion mass about 6 months after, which often wasn't the greatest in terms of patients having to go back to theatre. But by and large, most patients did reasonably well for a number of years with their Harrington rods. Now, John, what's been your experience with these patients? I'm sure you've got a bunch of them in the US.
Yeah, it's an interesting thing. I mean, they come in so many different forms, but I as you noticed on your post, they tend to form pretty rock solid fusions, and kind of giving credit to the people who did these without modern pedicle screws. They seem to get pretty solid, robust fusion masses through those regions, and sometimes it's so extensive that it makes certain correction options more challenging, right? And so, but I commented a little bit on this, that part of the reason I think they get such a massive fusion is that it continues to remodel throughout life. And so you see them 40, 50 years later, and it's like, a good analogy I'll tell my patients is, I broke my clavicle when I was younger. At first, it was like almost sticking out the skin, and now you can hardly tell that it happened. And so the body feels the stress lines of the bone remodels. And so you see that same thing in people with Harrington rods, because there's not that stress shielding. So that fusion mass continues to see the force of life. And I think that's part of why they get these very, very robust fusion masses. But yeah, non-union or incomplete fusion, once they get to this age bracket, is usually not the problem. It's usually issues above or below.
Yeah, completely correct. Although it's interesting, I did put up a case last week in another case session of a patient that had historic AOUSS rods for about 22 years, titanium, 6 mils, that snapped like an ankylosing spine fracture, which was absolutely fascinating. I mean, I think there's so much in this that we try to get our head around and understand, and we still can't always do that. But yeah, I've never seen a Harrington rod snap
That's
like that,
interesting.
but
Huh.
that titanium one did. But that was fascinating. So, look, she's basically, as you said, completely solidly fused as we expect from T5 to L2. She's had 10 years now of increasing lower back pain since her early 50s, really, and cervical pain. And she's seen the pain management doctors, and that's quite appropriate. And you can see there she's got a couple of neurostimulators in her buttocks on this EOS scan. And with this scan, she's got leads going up into her cervical spine. She's got leads over the sort of clinial region and sacroiliac joint. Um, this type of peripheral neuromodulation is not uncommon in Australia to see for more cutaneous and superficial pain, where the patient may have a lot of point tenderness. It's something that I've done a little bit of, particularly for clinical syndromes with mixed results. It's not a bad technique. It's not particularly dangerous, but these devices are not MRI compatible and they are relatively expensive. But it can work really well for some people. And she got some bit of short-term relief with it. You can see I've done a few numbers there in 2021. She had these are films from 21 where she had a lumbar cob of 21 degrees, an SVA of 50 millimeters, a lumbar lordosis about 30 with a PI of 52. So she's got a 22-degree mismatch there, but it's probably, if you calculate, a little more than that in terms of a more advanced formulas. She's got a 15 millimeter coronal imbalance and a T1 PA of 29. So she then has gone on to develop a right leg radiculopathy. And her neuromodulation devices, as I mentioned, put in peripherally, these are not MRI compatible, but a lot of them are MRI compatible if they're in as leads for the spinal cord. So her devices were removed to have an MRI. And this is the MRI she had in 2021, sort of going into 2022. And you can see in the cervical spine, there's a bit of early upper stenosis. It's mainly degenerative disc disease, and the facets aren't well shown there, but she has a bad cervical facet arthropathy as well. In the lumbar spine, she's got really L3-4 is pretty clear. She's got a far lateral big osteophyte. L4-5, she's got a significant degree of facet hypertrophy and some lateral recess stenosis. I would not call it severe. And at L5S1, she's got lateral recess stenosis on the right, but also foraminal stenosis. And she actually went and, after her pain management doc realized her radiculopathy was worsening, they got the devices out and got this scan. She went to a colleague of mine who I consider a very good spinal neurosurgeon, certainly generally conservative, and actually had done the right thing by getting full spine x-rays and full workup before talking about surgery. Patients with prior fusions, particularly going through the trauma of how Harrington rods were done, they're not often keen on fusions again. And even though she had a sort of 20 to 22 degree coronal curve, decompression was offered here for her radiculopathy. So she underwent a micro/tubular L4-5 lateral recess at L5S1, so lateral recess and foraminal decompression in 2022. And unfortunately, it was complicated by a CSF leak, which can happen to the best of us. And she ended up with a little persistent pseudomeningocele, but no ongoing symptoms from that after a couple of months. And then she reported that her leg pain improved substantially for 6 months, but started to deteriorate again over a further 6 months. And by about a year after this operation, she actually felt worse off. And so you can see the follow-up MRI there. And what's fascinating, John, I know it's a little blurry here, but she's had this follow-up MR. And what do you reckon's happening at L4-5 down here? She's
So
just progression.
yeah. So I think can you go back to the very first picture with the AP X-ray?
Of course.
There you go. So I mean, first thing when I see this and I hear right side L5 radiculopathy. I mean, right side leg pain, looking at this x-ray, it's like very predictable. The first thing that's going to be affected is foramen on the right side L5 nerve root, the bottom level tipping to the right side there. And so initial thought on fusion, non-fusion, how many levels, how big of a surgery is like, what are the goals of care in this patient, right? And so if the main goal of care in this patient is right side leg pain, obviously I didn't get to go through all the different images, but looking on that image and the direction that it's tilting at the bottom, all the right-sided shifting is L5S1. And above that, it starts going to the left again, right? So if it's going to be a foraminal problem causing right-sided leg pain, it's like almost for sure the bottom level alone. So then you get into this, which level is it? How many levels to do? And kind of the complications that come from CSF leak, et cetera, and potentially maybe even auto-fusing L4-5. I think that's what you're trying to get to is whether or not that, I can't see the image perfectly down the road, but it appears as if they did a surgery that maybe didn't totally adequately decompress the nerve. And when you do a decompression on someone that's already tilting, you take an incompetent joint, make it a little more incompetent, it's going to start tipping more. And I think you were referring to like what's going on at the vertebral bodies there of 4-5. I would need a CT scan, but kind of looks like maybe there's some autofusion. Is that what you're getting at?
Yeah, they're starting to autofuse for sure. And exactly why that happened, I wasn't 100% certain, but they definitely were starting to autofuse. And it was a sort of a tubular / decompression. And look, I think the surgeon, for the decompression, kind of did the right thing in taking off that 4-5 lateral recess, following the 5 root down and out into the foramen. And I think these patients, it is really challenging. To know whether to decompress or fuse. And as I said in the post, a lot of people will say to patients, well, you're better off just starting with a decompression. And I do think we've probably got to get a little bit more nuanced in working out when sometimes these decompressions are going to fail. And I don't think that this was necessarily the wrong thing to do at the time in terms of discussion with the patient, their mindset, and the imaging available. But, in hindsight, it obviously did cause a few issues going forward. So this is from 2021, before her laminectomy, before her modulators came out, to 2024. And I think you can see the deterioration there. So we've gone from a really acceptable coronal imbalance of under 2 centimeters to a significant coronal imbalance. The curve has increased. The SVA has increased, so she's lost her sagittal balance, but she's also retroverting her pelvis a lot more there. And you can see the difference in that sagittal X-ray, how the compensation mechanisms are changing. So her relative, she is sagittally imbalanced in 2021, but her legs, her hips are relatively straight. And now you're seeing the knee flexion, the hip flexion, bit of pelvic rotation. She's really getting out of balance. And on that EOS scan, I think if you zoom it up, you can kind of appreciate that L4-5 is almost completely fused there. And so she came along to see me after seeing a number of people for other opinions. And this was her films again, her long EOS films with a few numbers there. She's got an SVA of 60 millimeters. She's got a lumbar lordosis of 19 degrees, PI of 52 degrees, CSLV to C7 of 35 millimeters, and a T1PA of 36 degrees. John, do you use the T1PA a little bit? Is it something in your armamentarium, or is it something that you think is just left in academic centers? I've started using it more recently, just as a presentation tool, but also only because I feel it helps eliminate the compensation mechanism aspect of SVA. I don't know what your thoughts are.
I see huge value in it, but I also think that your institution, wherever you're operating at, has to have the right technology to be able to support using it, right? And intraoperative imaging, full-length scoliosis abilities. So that clearly is a huge, that is a limiting factor. I also, one of the things that I learned very early on is intraoperative correction. What you see on the table is not always what you see when they stand up, right? And so even if you think you got it just put right into alignment, or you think you overcorrected or undercorrected, there's some art to understanding that titanium rods are somewhat flexible. If and how you put the rod in and use reduction towers to either pull the screws to the rod or the rod to the screw, and depending on how much lordosis you put into the rod itself, it's going to look predictably different when they stand up. And so I love the concept of using that. And I think there's huge value if you have the right technology to do it. And so that's one of the things I'm fighting for is intrafolding scoliosis and being able to actually make those measurements in real time. So instead, I have to kind of look in my brain and see like, what is it going to look like based on pre-op imaging and project that. So I love that. I love the idea. I see the value. It only works if you have the technology though.
Yeah, I agree. And look, I think the other part here that I've put up is I think lying imaging can be very valuable when you're making these decisions. Okay, so we do all this standing imaging and we're doing numbers and everything like that. And planning is super important, don't get me wrong. But I've also just highlighted her MRI that I got pre my surgery. And, you know, she's a definite surgical candidate here. I'm not going to muck around with too much non-operative stuff, but I did see her for about 3 hours of consultation prior to actually doing the surgery because these are long and complex procedures. And, you know, we have to be realistic about what we can achieve. And also, I think these patients that have had a lot of surgery in the past, they're very anxious. You know, things haven't always worked out for them. So you really have to take your time and go through the details with them. But this was an MRI, and you can see the disease at 5.1 still there. But also, I've done a sort of rough lordosis measurement, and her lordosis doesn't really shift. Okay, so she's got now a 19-degree lordosis, whereas it was about 30 about 4 years prior. With a PI of 52 and a T1 pelvic angle of 36. And so even though SVA has only gone up by 10 millimeters, 1 centimeter, her T1 PA is increasing, and that's a reflection that the quite a bit. And that's why you know that she's recruiting those compensation mechanisms to even hold it at 60. So yeah.
Further loss of the anterior column, losing more lordosis, yeah, compensating more. I mean, absolutely.
Yeah. And look, so we're dealing with a fairly severe mismatch here. And in a patient in their early 60s, I'm wanting, you know, probably another 52 to 55 degrees of total lumbar lordosis in an ideal world. But then we have to respect the fact here that the patient has a flat thoracic spine, relatively. Okay, so this is where it gets super hard. And I have never seen a detailed paper telling us exactly where to put these patients. And I've got Alex on as well. It was awesome. Alexander's on AT, John. He's one of our faculty. He can jump in if he wants to. Because, you know, I freely admit that in Australia, my German is not very good. There are a lot of papers in Germany and France and other things that we don't always get to read. But Alex, are you aware of any sort of papers guiding our alignment goals for these flat post-thoracic fusion patients, you know, as opposed to us based on our normal alignment or gap scores or, you know, those sort of things?
Yeah, hello, Mike, hello, John. Great to see you here. Well, no, actually, in the German literature, in the French literature, we all can't say what is the goal, where to go. And I have to say, we see them less often. These patients are dying with this herring rods. Nobody, I've never seen any colleague here who dared to do some osteotomies in a post-Harrington situation. Even me, I would refuse to make just an implant removal because it's better to work around and leave this straight, flat thoracic spine like it is and to adjust best as possible in the lumbar spine, which is uninstrumented. But it's really hard. I've never had a patient like this here, so I can't contribute with good science or personal experience.
And I thank you, Alexander. I appreciate it. If I go back, one factor to me in making decisions on this case, and I'll just run back a little bit. Her cervical MRI does show she's got a little bit of upper thoracic because kyphosis. So she's fused to T5, and the apex of thoracic kyphosis is usually either T5, T6, T7 for most patients. And so she does hinge a little bit off that, but she's been like that for a very long time. So, and you know, I respect we may have to come back there, but at the moment I really want to deal with her lumbar problem. And she had this CT scan as well. as part of a workup, and this concerned me a fair bit. So she's got this CT scan here with this huge bit of sort of calcification in the lateral recess and on the dura near where she had that CSF leak. And I've got neurosurgical friends, including the person that did this original surgery, and I look at this and go, if I do a PSO here, this is going to be big trouble. You know, getting around this sort of calcification, you know, previous CSF leak, residual small pseudomeningocele. So, yeah, this is where I have to look at other ways of doing this surgery. But with all this information, made a plan. I think, you know, John, just not knowing if you don't know what I did, if you didn't see my
I don't
post.
know what you did, but I do have a couple thoughts on that. So,
Yeah.
so risk of CSF leak, I have a wonderful case I'd love to present at some point. I'll present where the facet joint had grown in similar even further, where you could almost see that the joint was, you could see the dura wrapping almost circumferentially around the facet joint in the canal, and it was totally obliterated, and got a massive hole. By the time I got the facet joint out, there was like a coin penny size hole in the dura, and I had to augment it with pericardium, and it sutured up really nicely. I mean, it was, but when I first saw it, I was like, oh my gosh, this is a big problem. But the one thing that I would argue with what you're saying about PSO is that when you do a PSO, and even if there's a history of a durotomy, you are shortening the posterior dura. And so it actually makes, it's like the one scenario where I don't even care if I get a CSF leak or a durotomy, because it's going to be so easy to close as you then do that PSO and you shorten that posterior elements, you bring the dura back together, and it like closes with redundancy, right? And so I totally agree with what you're saying. And doing a PSO where someone else has operated and all that, I do think though, I've done these where the entire lamina is missing, or there's been CSF leaks, and the huge thing is that you close that down and you actually have redundancy. So it is a possibility, but I also see the hesitation in it because you're not looking for more problems.
No, and I do agree. I've certainly seen little leaks at the back when we've been doing, well, only ever revisions. I've never had one in the primary PSO case, but I think that's where I'm always a little bit anxious about that, and the sort of the bits that go with that, and the potential wound issues and complications, and just remembering that there's already a scar there. She's already had a small pseudomeningocele, and I had this big desire to keep that compartment over the midline lamina intact.
The other thing I would add that you were talking about earlier, like how high do you go? Do you need to cross above the Harrington rods up top? So there's a big difference, I think, in taking someone with a iatrogenic flatback fusion with a similar looking spine that's not been instrumented like this or fused, and they've got this iatrogenic flatback, and you're going to take them up to T10 or cross the apex, like trying to make. So those people with iatrogenic flatback, this woman's been living, or man or woman, they've been living this way for a really long time, and those upper segments above this fusion have had so much time to react to those changes. So as long as there's no cord compression up above the Harrington rods, I actually worry, independent of T1 pelvic angle and all that kind of stuff, I worry less in a person like this of junctional failure above than I would a person who you're taking them up higher for the first time. I mean, even if you corrected them 20, 30, 40 degrees or back to anatomic, there was a time in this person's life when they had anatomic lordosis and it tolerated that, right? And so I think this is a very different scenario than taking someone primarily all the way up across the thoracic junction.
Yeah, I agree. And that's where I think it'd be great. I've already talked to Michael Galgano, who's one of the other faculty members here, about putting some cases together on what happens to these patients, and working out what we do. And I think for me, this case, I'm really trying to do an anterior column reconstruction and avoid a PSO, because one of the aspects of PSO, and I've been guilty of this with a historic case maybe 10 years ago, is by doing a PSO, I think I overcorrected the patient and I made junctional problems at the top. And a PSO is a very acute correction as well. And so you may not have that more harmonious balance that you can get out of the anterior column techniques. And that's just another factor in this for me. So this was my plan. I really want to avoid a PSO and avoid CSF. One of my previous fellows, who was an Austrian trained in Germany, who worked in Switzerland, great guy, and he used to call it the spine water. And we'd be operating, and I'd be sort of at the back of the theater sometimes, and he'd go, "Mike, I've seen the spine water," and I go, "Oh." So I don't love managing CSF. I'm very upfront about that. I mean, I can do it, but I really want to avoid it if I can. And as John talked about before, and as Alex has talked about, you want to avoid removing the Harrington rods if you can. And Uncle Bob Gaines would probably be at me and tell me that they're easy to get out, but these things are a pain to get out, and you will break your instruments. You will break your osteotomes. You will break your chisels, because you have to drill and mine the bone. It's like mining in Minecraft. You get your kids to do it, right? They are, you got to get through the bone to get these things out. And then you got to cut them. I mean, I think an end-on-end connector for some of them is okay, or a side-side if you want to dig out a little bit. And I've seen Alan Daniels do that. But I like to avoid removing them altogether. And obviously, I want to restore sagittal balance and coronal balance. And so to start that process on an anterior column reconstruction, I'm doing an ALIF at L5S1. And in this particular case, you can just see she got a nice vascular window. You can see my retractor set up there. I use pinned Homans with soft blades as well. The pins sit behind the iliac vessels and just hold that bifurcation open. She had a good window, and I like to do a cage plate construct for most of these. The interesting thing about a cage plate, it's strong, but there's still a little bit of flex in it. So when you come to the back and remove the facets, you can compress an extra couple of degrees. So this was stage 1, relatively straightforward surgery between 60 and 90 minutes. Look, I mean, I know in the US and I know some parts of the world, you need to have a vascular surgeon or a general surgeon for these. I've got a very good friend and colleague who's a general surgeon here, and he and I do about between 65 to 70% of my cases together. He's not always available, so the easier ones I still do myself, and I think I actually did this one myself, but very, very straightforward. One thing I've done here that you can't see on the pictures is I've taken the PLL, and I think when you do these hyperlordotic cages, I think you can really get yourself into a little bit of trouble by not taking the PLL, and then the back of the body, even though you get the cage in, it opens up, but it hinges on the PLL instead of opening more smoothly or symmetrically. So I'm really rigorous about taking the whole back down in these cases, like a giant ACDF. Some extreme angles, you can't do that. It's one of my reservations about lateral ALIF, but you may be able to get over that with the scope. I don't think lateral ALIF is a bad technique. But for this particular case, that's a 25-degree cage, good end plate contact. You can see the back's opened right up as well. John, any comments? Alex?
Yeah, I even use the same retractor. I mean, the good thing about social media for surgeons, and John, you mentioned today that you entered LinkedIn 1 year ago. So I entered social media like 5 years ago, and I learned a lot from Mike Selby, and I was so unhappy with several implants. And so I learned from watching images online. And so I switched my implant to the same construct combination of an implant and a plate. And it's a cage and a plate separated, and it gives me so many degrees of freedom in L4-5, L3-4. And so I cannot contribute today that I do it different. I just do it the same as Mike Selby because I follow him.
Alex, too kind. But I want to know if your results are okay.
Yeah, it's good.
Yeah.
Hey, so my thoughts, man, I love this. I love taking advantage of hyperlordotic implants. How many degrees is this? Is it 25, 30? I mean, it's 25. Is that what you said?
Yeah,
25 degrees. So that is amazing. And you get a whole lot of lordosis down low, reconstructing the anterior column. Obviously, there's several pitfalls with hyperlordotic ALIF that I think a lot of us know about, which is giving someone foraminal stenosis. So we're trying to correct this person's right side leg pain, and you're doing it through hyperlordotic ALIF. It's likely a mostly foraminal problem causing her leg pain on the right side. So how do you accomplish that, but also use an implant where the posterior height is much lower? So you got to get that implant very deep. You want to use one of the tallest implants that they have, figure out a way to slowly expand it. And I think you've done that very nicely. And actually during the approach on these patients, I kind of actually like it if the access is a little bit towards the side of their symptomatic foraminal stenosis. I'd rather, if they have a right-sided foraminal stenosis that they're symptomatic on, I'd almost rather cheat my implant on the right side. And part of that is because the bone quality is better on that side. Their bone has been seeing the weight over and over and over, year after year. They've been developing sclerotic margins. And so sure, like you don't want to put the cage into the foramen, you don't want it to be too far lateral, but I kind of want it to not look midline. And so that's kind of one thing that I would add is recognizing in a deformity where the bone quality is good and where it's soft is really valuable.
John, that is an awesome point. I'm going to go back because I would usually have biased this cage another 3 to 5 millimeters to the right. That's pretty midline right there. But I'll show you why I didn't do that. If we go back, so here, this is what got me in the planning for this case, is that if you can imagine jacking up the right side there at the base of the spine, we know that our interventions at the base have a bigger upstream effect than anything else, right? It's actually going to tip her even more coronally imbalanced to the left. Do you see what I'm saying? Like if you jack that right side up even more, a lot. So I was trying to find a balance. So in the end,
is your plan, I guess I don't know what you ended up doing. So I don't know if you fixed that other curve or not. So
that's the issue. The issue for me was because I was trying to avoid a PSO, because I could get that back with a PSO, to not go as much to the right here. So that was a decision, and I'm completely with you, and I usually do exactly what you said, but in this case, I made a conscious decision to just put this midline. And then, I think Alex might have found this as well. When you do cage plate, it's strong, but you can still get a little bit out of the back, particularly when you take the facets off with big pedicle group. And so you can do a bit of fine tuning and adjustment back there, but you've got this kind of pivot point to compress on. Right. So when when you come to the back, you actually have most of that lordosis set, and it makes your life easy in that respect. So one thing I get asked about a lot is about, how it helps staging surgery, etc. And, as a surgeon, I'm not as good in hour 9 as I was in hour 3 or 4. I like to stage. It gives me a bit of an idea of what's going on. So I've got the CT scan in between stages, and you can see here that L45 is pretty clearly autofused. You can see the cage has pretty good end plate contact, and that we've really got, with a 25-degree cage, about 20 degrees of lordosis out of that segment that was previously flat. And you can already see her starting to kick back into better alignment. And then that's a CT scanogram, and unfortunately, they didn't do a whole one for me. But I felt on this, she was already starting to tilt back a little bit favorably just in that lying position. And so it again convinced me that I hopefully do this without doing a PSO as a stage 2 case. Any comments from John or Alex at this point?
Yeah, absolutely. I think avoiding PSO, just one point, these patients with such autofused L45, they tend to have solid fusions if you have a properly mechanical stable construct. Yeah. And the main reason I don't go for decompression PSO is that you don't get just a tiny CSF leak, because sometimes it's bone and then it's CSF, and you're looking for dura, and there's no dura. And when you think, okay, I have to widen up a little bit the surrounding, I have to resect or drill down some more bone, you don't find dura in a revision scenario. It's like the CSF is held in the spinal canal by osseous borders. And the attempt to to decompress can lead to huge CSF leaks, like centimeter long leaks, impossible to suture, with just a scenario where you think, okay, I won't be able to fix it. I have to close it somehow and pray that it will heal. So I strongly recommend not to go for any decompression in a revision scenario in patients with these kind of bony growth potential, because I doubt that there is a dura you can suture or you can patch or you can suture in some pericard, because there's just bone.
Yeah, no, and that's a big thing for me is that you know, I'm not that good at taking fascia lata or other repairs, but I do have a lot of friends who are neurosurgeons that will always help me out, which is good. Look, for this type of case, the other thing is in my planning, she needs a bit more lordosis here. She's only got one mobile disc left at L3-4. L2-3 is autofused again with time. So this is now we're sitting on a situation where I've only got one more spot to correct through. And for me, that's going to be a prone lateral. That's the most powerful correction I can do at 3-4. And I got this CT partly also to plan 7D. So I've used 7D navigation now on quite a few occasions to get around Harrington implants. John?
Yeah, I just want to add, so I love the concept of staged, and it's something that I wish I felt more comfortable with. I'll tell you my biggest concern. My biggest concern in staged is that despite the fact that you took the PLL, it probably takes some tension out or closing wedge pressure off that ALIF cage. Your whole case is surrounding this hyperlordotic ALIF. And if that patient is standing up, walking around for a few days at the hospital and fractures that, it's like game over, right? And so in my hands, I guess one difference is I'm not brave enough to leave this and do it a couple days later. I mean, I would want hardware that same day in the back to mitigate risk of subsidence, because your entire correction is surrounding staying away from PSO and this 25-degree implant.
Yeah, and look, I completely agree, John. I suppose I've done a lot of stage surgery over the years, and I have only had subsidence in between stages where I've probably made a technical error of, you know, burying the cage a little bit in the end plate or other things like that. In the older patients where it probably is more important, I now put a bit of cement from the anterior approaches under the end plate, and I haven't seen it since then. This is why, though, I use cage plate, because I do feel it's less risky with cage plate than integrated. And this patient, I was very aware of those long lever arms. So basically the staging was only three, was it? No, actually staged for a little while longer, it may have only been about 3 to 5 days for this patient. So it wasn't a long time in bed. It was, and when I get them up on a gutter frame. So they're not hinging forward. So I'm quite particular about how I do these things. I completely appreciate the point. And you probably could have done all this in one go. I suppose I just had a few uncertainties and I didn't want to be making a decision to do the PSO on the fly. So that's why I chose to stage. But I think it's an ongoing debate. And it's a very good point John raises. There is definitely a small risk of catastrophic failure. All right. So this was my stage 2 plan. So I use 7D navigation, which is this light-based navigation I've talked about on this platform before, and I've used it on a number of occasions to avoid Harrington rods or CD implants, because they were often placed, Harrington rods in particular in the midline with little hooks. You can avoid them by accessing the pedicles laterally. I planned a prone L3-4 lateral with expandable titanium cage and allograft, and then an L3-4, L5-S1 navigated facetectomy. And that's the other joy of navigation, is knowing from the pre-op scans where that pseudomeningocele is in the midline. I can navigate at least very deep into the facets and get to dura and do like a pseudo SPO because the back's already been taken off. I always do bedrock SIJ fusion and a kickstand rod. So that was my plan at the back, and taking her up to about T9. And I've got to show you the result. So surgery went smoothly at the back. I used neuromonitoring. What was interesting is after the 3-4 cage went in and I expanded it, although the motors and sensories were really good in the lower limbs, I got a lot of kind of EMG activity for quite a while afterwards. It was sort of this spikes of EMG activity that were happening, probably from a significant degree of neural stretch at that point, because she's got so much ankylosis, both iatrogenic and natural within her spine, that there's just not a lot of plasticity there. So again, with that change, just by expanding the cage, made me a little happier again to avoid a PSO there. But those screws are all, she's had a CT scan, those screws are all in place around the rods. The bone quality within the fusion mass, although the fusion mass can be big, really sclerotic on the outside, the internal bone quality of a fusion mass can be poor, and we always have to be aware of that. I was ready to cement these just in case, but actually the screws felt pretty good going in, so I avoided that. She's also got a little kickstand rod there, which I use to help with the correction or support the correction once it's done. But I really worked hard here on squeezing down, as you can see, that facet on the right at L3-4 over the top of my cage. So I've used that as the pivot point to kind of undo that coronal decompensation, as well as keep some lordosis through that cage. So yeah, I was pretty happy with this result radiologically. Those neurological symptoms, the neurological EMG spiking actually did cause a bit of sort of diffuse neuropathic leg pain for a little while afterwards, and that has now settled down. And I saw her the other day, and she's doing very well. Yeah. And a couple of questions on the thing. Raul Pope said his goodbyes. Thanks, Raul. Ismail has asked, what are your thoughts if you don't have anterior plate, posterior fixation or standalone? So we were just discussing that. And I think the plate gives you not complete security, but a degree of security in between stages. I think I've also, where access has been hard and there've been vessels hanging over, sometimes the integrated screw angles are really hard. So you can just use blocking screws. Sometimes I put a blocking screw at the front just by putting a screw through the tip of the end plate. So old school orthopedics, right? So that's something else I do as well. If there are any other questions on the chat, pop it on. But this is the final result there. Sorry, I'll just pop that back up. In terms of the CT alignment. So I'm pretty happy with what we've achieved. All those, as I said, the neuro symptoms have settled down. Hopefully we'll go on to become solid. Got enough bone graft there, both interbody and at the back, posterolaterally, avoiding the midline. But yeah, keen on any comments and thoughts on the case. John, Alex?
Yeah, pretty impressive. You did just 2 interbodies and corrected a deformity. And that's quite impressive. I think this is minimal invasive from anterior column restoration and achieving a perfect, I think not perfect, but it's as good as you can do it with these 2 approaches. You went from the right side. I think with navigation, you could plan incision.
Yes. Yeah, absolutely. So right-sided prone lateral, navigated incision planning, completely correct. So the 7D, so with the 7D workflow for this kind of case, do is we do
yeah, it looks really good, Michael. It looks really good. And I think you could have used the Harrington rod intraoperative like a cable, this cable control of the coronal correction. And I guess you have seen intra-op that the rod was tilting less than on the pre-op standing X-ray. It looks really good.
So, I mean, I think it's a universal thing world over, but sometimes the text don't save all the pictures. And I know that John gets intraoperative plain films. I've been very impressed with his ability to get intraop plain films, which I can get APs, but we're not set up for laterals. So I use the OR. You can use other image guidance systems as well now for long stitched films, and we kind of stitch them all together. So we did that during surgery because that was really important to do here. But yeah, access to long intraoperative films when we're making these kind of decisions, I think is kind of important.
A couple of things as I look at it, man, awesome work as usual, man. I mean, you touched on so many points that if people listening might have glossed over, but you know, the thought behind the bone density and pedicle screw fixation in someone with a prior fusion, and having cement augmented screws available because these, even though there's a rock solid fusion, the pedicle bone usually isn't quite as good. I mean, like, man, that is such valuable information. And so if you're going to take on a case like this, understanding that before you go in is very important. Every type of autofusion, or surgically fused, or TLIF versus ALIF, the type of fusion mass that we encounter is so different. And what that does to the surrounding bone is very important. And absolutely, man, I wouldn't be surprised to find that you stick a screw into one of those upper pedicles there and it just wants to rip right out. I mean, so having that available is very important. You can also look at this and predict, based on the curve pattern, that those low thoracic screws on the left side, those pedicles are going to have better fixation than on the right side because they're on the concave side of the deformity and they're feeling those stress lines more. And so it's even laterality, you can have an idea of which side's going to have better purchase. I guess some commentary, beautiful reconstruction. I love the fact that you're not afraid to go on the right side for XLIF. I think that there's so many people that think that's like a contraindication or like almost malpractice to do. It's not. I mean, you got to stay away from the vessels. You don't want to injure someone, right? And so certainly the aorta is a beefier structure. It's harder to injure, but like, when is the last time I poked the aorta? Like, if you're worried about that, you shouldn't be doing an XLIF on that patient anyway. So same thing with the vena cava, right? So as long as their vena cava anatomy is amenable, it's a great option. Other things that I see here that we don't have the answers. And I think you've admitted this in the past, which is, the bedrock, the value of bedrock. I think one of the things we do have some more information on, and I think you could argue that maybe it's not needed with ALIF over PSO. Why do you just use 2 pelvic bolts instead of 4 or 3, right? And so there's some data coming out that says that 4 pelvic bolts is better than 2, whether it's iliac or S2 iliacs, is better in long term. And so they also, there's implants out there where you can accomplish both at the same time. So it's a SI fusion bolt that also has a tulip head on it. And so you kind of wonder whether there's a way to integrate both. Also, we don't know the answer to SI fusion quite yet. And that'll be kind of interesting to find out.
Yeah. Well, John, I don't want to spoil it for the researchers involved, but there will be shortly a randomized trial coming out on bedrock. Results will be published soon. I wasn't involved, but I do know who's been.
No, and I'm aware, and I think we'll kind of learn about that, but also begs the question, like, okay, but what about 4 bolts? And now we've got 6 bolts. We've got 4 into the pelvis, plus we've got bedrock, and how much real estate, and are certain people, their pelvis may not have enough real estate, right? So I think that there's a lot going on here. I do love the fact that you have anterior column support, even though you only have 2 pelvic bolts. It probably doesn't matter, right? And having a PSO without 4 is a little more concerning. Man, I think you did great work. This is awesome.
No, thank you, John. Well, time will tell if I have to do anything, particularly in the thoracic spine, upper thoracic. But yeah, I was happy with the overall result. The SVA here is sitting at about 25 to 30. It's not perfect, but I'd prefer that here than. And if you look, the compensation mechanisms are gone though. So to me, yes, the SVA is halved. We're back near age appropriate, not completely perfect. But the compensation mechanisms have gone as well. And that's, within 3 months, I'm pretty happy with that. So, yeah, I like the long-term outcome.
I have a great question for you here. So what do you tell this person long-term? This is, how do they mitigate risk above in their upper thoracic region?
So the thing for me, and there's no science behind this, but I get them all after they're comfortable post-operatively doing like a Pilates, yoga, stretching kind of stuff for their shoulders, their neck, and their hips in particular. And I tell all these patients, your hips may well wear out, particularly with me being quite aggressive with the bedrock SIJ technique. I think that will put more stress on the hips. So I'm getting people to do, regular stretching to really try to improve their lower limb mobility so they can compensate, and also up the top end. For what it's worth. And look, this patient's had you can see had a shoulder fracture and got a plate on there, which was a bit unlucky, journey. I think you have to keep these patients moving. And so we're lucky in Australia, it's generally pretty hot. Most patients are pretty happy to do aqua therapy, so hydrotherapy, aquatic exercise, these sort of things. And you've got to get them motivated to keep everything moving.
So the big question is bending to the floor, lifting from the floor. What are your thoughts on that?
I still let them do that, probably not for 6 months after a surgery like this. And we've got pretty free access to CT in Australia. So I'll CT scan her again at around that 6 to 9 month mark after surgery. And if I've got good bone growth through those cages and posterolaterally, then we'll be pretty much letting her do whatever she has to do within reason. I do think in a case like this where you have basically no shock absorbers left in your spine from T5 down to the pelvis, I do avoid things like road running, those heavy impact activities. But these patients all still go on holidays. They lift their suitcases on and off the carousel. They do all that sort of stuff. Yeah.
So I totally agree with everything is in this patient, right? So I think that this particular patient, because they've lived with this longer fusion, I actually think their risk of junctional failure is lower than many others. The
Yep.
bone up at the top has had time to remodel. I really worry about female gendered patients, 60 to 70, especially, where they now have a T10 to pelvis, who have, those are the absolute highest risk for junctional failure, independent of making perfect parameters. And they always fail the exact same way. Not always, I don't like the word always, but they almost always fail the same way, which is through bending, right? Flexion. And so I think that is like I think that that is my biggest concern in these patients. And I am annoying in that I think that all these parameters are very important and we should strive to hit them all just right. To me, the best way to avoid junctional failure is postoperative restrictions. And especially in those very high risk patients, it's almost more important than correcting the deformity, is teaching them the lifetime restrictions of living with a T10 to pelvis. Anyways, wondering what your thoughts are on that.
I'm not as restrictive as you, John, so we could definitely do a nice little trial on that.
Love it.
I'm pretty big on exercise. And so a lot of them are doing extension-based exercises for their upper thoracic spine, which I think can mitigate against some of that as well. But again, it's kind of a, level 6, my opinion, not even expert evidence kind of thing. So, we're coming to the top of the hour. Oh yeah, Alex.
May I just say, I've seen a couple of these long constructs, and suddenly I get a call, leg pain again, and in my personal experience, I see them going to total hip replacement a lot more often than having a proximal junctional kyphosis. I fully agree with John when you say they have a solid situation over there for decades. But the hips, I'm worried about the hips. I guess sometimes we as orthopedic surgeons should tell our younger colleagues who do total hip replacement that these pelvic tilts and this requires some skills in planning for the total hip replacements. This is not an easy total hip replacement. They should know all these parameters, and our colleagues are doing really great, following some new rules. But I'm just worrying about the hips and let's say the knees as well.
Yeah. Well, I mean, there could be an argument here for like a dual mobility cup, right? Just to, again, keep that more mobile hip area and keep the pressure off the upper thoracic spine. But yeah, those are things that we're still working out. I think, hey, it's going to be a long time before we know all those answers.
Yeah, and luckily, sometimes patients come in with a whatever femoral head necrosis, and they get a total hip replacement before your deformity correction.
Oh,
And
yeah.
then they go into some troubles, or other colleagues like to cut the psoas tendon for obvious reason. And I think we have to talk with our colleagues from extremities a lot more often about these kind of patients, because otherwise they run into an unhappy situation.
Agreed. All right, I'll just have a little look. There's no more questions on the chat box. I want to say a big thanks to everyone that's joined today. We're heading to the top of the hour. Sorry, we lost 5 minutes with me mucking around with IT issues. But I want to thank John for joining today. Just amazing to have him on. He's been a very valuable contributor, perhaps the MVP over on LinkedIn since he joined.
Yes.
And I think I've got Alexander as well on here, and I love his insights. And thank you for staying up late to hear me rabbit on. Appreciate it. And Ali was on here before, and I've got to say a big thanks to everyone who joins us. Lots of faces and names I recognize here joining week in, week out. This will be on YouTube a bit later on. And my final big thank you is to Amna, who runs this in the background, Dr. Amna Hussain. She's down in Houston as a research fellow, and she does a fantastic job keeping us on track. Next time, I'm going to bail John up now in public and say, John, we're going to talk about one or two of your cases, or one or two of mine in another session, because I really love
Sounds good. Thanks so much for having me.
Good. All right. Thank you, everyone.